Okay, so medical management is like less effective than surgical management because it's only a temporary method. It's anti-fertility. On any kind of medical management, the patient is not able to, will never be able to conceive. Then we come to, so we said myomectomy is the only way to preserve fertility for fibroids. Now, what are the roots of this myomectomy? It could be by open surgery, what we call as laparotomy, where we give an incision, either a vertical one or a horizontal one on the abdomen. It could be tackled vaginally if the fibroids are, say, located in the cervix or in the lower part. It could be done as a minimally invasive surgery by and then so laparoscopy has been around since the 1970s. It's slowly now which we call as robot hands. The thing in myomectomy is because we are removing part of the uterus, we are suturing back the rest of the uterus. It's very, very important that the suture line is very good and it's a very robust suture line. And the way to ensure that used to be open surgery back in the day, because we would feel, see, and touch the tissue and know that we have done a good closure. But now with the robotic platform, we can do the same thing, everything as good as the human hand. So what are the basic steps of myomectomy? The first and the most important one is to map the number of fibroids, their size, their location. Usually you do this either with a very good 3D ultrasound or using an MRI guidance, and that tells us exactly the fibroid is, say, from the serosa or from the endometrial cavity. How many are they? How big should it be? Hysteroscope? Should it be abdominal? Should it be a combination of these technologies? Then, if it is an abdominal surgery we are planning, because robotic surgery cannot be done vaginally, so I will focus now on the abdominal axis. So then we gain access into the abdominal cavity. So gaining access into the abdominal cavity, if it is the robotic version, will be through small holes, which are all less than a centimeter in size. One usually at the level of the umbilicus, and then lateral ports on either side. After that, we visualize where all are the fibroids. We plan the incision we are going to give, because wherever we give the incision, we also have to suture that back after the fibroid has been removed. So all of these steps I'm outlining now, but you will see in the surgical video that I will the vasopressin. Now vasopressin is a kind of a vasoconstrictor. So we inject that in the subcapsular location, which means just below the capsule of the fibroid. And what that does is it just for a short period of time, say about 30 minutes, it just constricts the capillaries, because otherwise a fibroid bed bleeds quite a lot, because there is a lot of vascular supply of the uterus going into the fibroid. So the bed tends to bleed a lot, and we want the patient not to lose too much blood. So that's why we inject this kind of agents to reduce the blood loss during surgery. Once we have sutured the capsule back again, it doesn't bleed. But whilst we are separating the fibroid, wherever the blood supply is coming from, it does tend to bleed. Then the aim is to enucleate as many fibroids as with single incision. So the less incision, the less damage is there to the uterus, and it becomes also easier to suture. Then we suture the fibroid bed in layers. It's very important not to leave any beds between them, because then blood tends to collect. Like I told you, a fibroid is a very vascular condition of the uterus. A lot of blood supply goes to it actively. So that's why it's very important to ensure that the hemostasis is complete. And then after that, we remove the separated fibroids. Usually we give a slightly bigger incision, put them in a bag, and then remove them. So now why is the reason that we are going from, say, open to laparoscopic to robotic? In open surgery, we have to give a very big incision. Now, where we give a big incision, risk of formation of hernia, healing is not good. Then a form. So the big gene that is given more, something is going to be stuck. This is more blood healing takes an infection at the day and open. We used to do open always blood. Right.
Yes, doctor.
So the risk, there would be more need for blood
Doctor, your
transfusion. So we
screen
would
is not
always
sharing.
keep blood at hand when we were okay. From my side, it is shared. Just give it maybe a couple of seconds.
Yes, ma'am. Yes, ma'am. It's there.
Right. So there was always blood was kept cross-matched for myomectomy. 2 units as a given. We would always transfuse, even if they didn't lose extra, and they would always lose more than that. So there would be more units of blood. And very rarely now it isn't seen in today's date. But sometimes when you are doing such a bloody surgery, you are dabbing everything, cleaning. Sometimes, very rarely, you could lose a mop inside, which cannot happen in a minimally invasive procedure because your incision isn't that big. So that's why minimally invasive became popular, and then traditional laparoscopy came around, and a lot of people started doing myomectomies by laparoscopy. But there again, over time, people noticed that because of the way the instruments are, you can only use it in a two-dimensional manner. So you have a limited angle of approach. You can either move them up or down or left and right. And because of that, sometimes when you have to suture in very weird angles, it becomes difficult with laparoscopy. And as a result, the integrity of the scar is not so good and the precision is the camera that we use for laparoscopy is also a 2D camera, so we don't get a perception of depth. Again, all of these lead to slightly reduced perception compared to looking directly with our own eyes. And because of that, where the cases are generally were not doing because laparoscopy is very challenging. So surgery has a role overcomes the limitation of complex laparoscopic surgery. And I'll show you why in a minute. So basically, it was developed the limitation areas in laparoscopic procedures. And to enhance the capability, it has years it the patient or not standing next to the patient. It is. So how did the word come about? Robot was coined in 1920